Thank you very much, and thank you, YY. It doesn't matter. I always will learn when you are presenting new things from Singapore, and you're not just stealing. We are copying what you are doing, actually, and sharing it things. I'm going to follow up on the AI project. It was mentioned this morning in the very interesting presentation on the future. And I'll go and bring results from a future project, which is not the future anymore. It's actually here. It's about improving patient care in dispatch center using artificial intelligence. You got my conflicts of interest. I just want to mention that Coty, the Danish company, is a partner. We don't get any money for them. We work closely together with them. Actually, we pay them for their software because we want to keep the science and the knowledge we gain apart from their commercial interests. But you'll get the story about Coty later. This presentation, how to improve survival in cardiac arrest. We want to see if we can identify cardiac arrest because it is early, because it's important for survival. And what is best performance, humans or artificial intelligence or machine learning? And then what is the potential in EMS for the future? And then, of course, an invitation to collaboration to EMS organization internationally here in Australia. I come from Europe. I'm not going to compare Denmark with either Singapore or Australia. I just mentioned maybe I should because we could include Greenland, which is actually up there. This is Greenland. So this would make little Denmark much bigger. But then I thought again, climate change or climate crisis might reduce Greenland to, I don't know, a small island in the end. I hope not. But wonderful Copenhagen is where I come from. And I'm going to present work that has been done by Nikolaj Blomberg, who is a PhD student in Copenhagen working with artificial intelligence. He actually won the best abstract from the European EMS Congress last year. And he has recently, this year, published his results from a retrospective data analysis in Copenhagen for 1 year. And I'm going through that and the conclusion as well. We started with how to improve survival rate, and we have seen an increase. We looked at the Global Resuscitation Alliance recommendations. We see telephone CPR, rapid response, rapid dispatch, AED programs is important, and we thought that maybe we could use some kind of modern technology to improve that. We have seen that we have improved triple survival in Denmark for 10 years, but we have seen that there's we don't increase bystander CPR rate anymore. It's about 67-70% in total, and we just wonder why. Why can't we get the last 20-25% there of bystanders to do CPR? And then because we know that dispatchers identify, well, first of all, bystanders will call and say there's a cardiac arrest, or they have identified it themselves in about 20% of the cases. Dispatchers identify another 50 or 60%, but leaves us still with 20 or 25% missing. And if we miss them, we will not guide on CPR, and we will not refer to an AED there. So we might consider it still as an emergency, but we will not handle it as a cardiac arrest from the very beginning. And we know that the impact is on the first link in the chain of survival, meaning the dispatchers. So we thought that maybe we could do something there. So this is just the figures about the role of the dispatchers, and that is documented in scientific publications. If they recognize cardiac arrest, they will double survival or more than double survival. If bystander do CPR, there's a 400% increase in survival as well. And if an AED is being used, we have seen these data from Australia as well, survival is usually 50% or even more. So the dispatcher can actually stop the clock at an early stage. Could we use AI for that? Can Coty do it better than humans? I'll just give you a short story about Coty. When they turned up in our office, I actually sent an email saying, we know you have a lot of data. Coty at that time were 3 bright guys, IT guys, look like IT guys, have been working with big companies, but they got some great ideas as well. And so they turned up and said, we know you have a lot of data, and we have a great idea. And the idea was to identify patient dissatisfaction during the call, meaning when patients or citizens are calling, we do the triage, we handle the patients, and afterwards we get some complaints in some cases. And I thought that maybe we could identify those complainers at an early stage during the call and then correct the dispatcher's attitude or the assessment from the dispatchers during that call instead. And we said that sounded really interesting because we're doing patient satisfaction surveys every day on the call, so they get an SMS and reply to that. But if you could do it before that, even that would be much better. But then we thought that, well, we've just been doing a PhD on identifying cardiac arrest, and we noticed that they only identify 75%. So don't you want to save lives instead? And then the whole game changed, and they said, we can do that. Well, yeah, a lot of people think they can do that, but we thought that, okay, let's try it. So we gave them some data from our dispatch center, some voice calls, old voice calls, and they listened to them and came back and said, 90% cardiac arrest. We know it was 100%, but we also knew that our dispatcher would only identify 75%. And then they got another sample, a lot of calls, came back, said 2%. We said, no, there's 0 cardiac arrest as far as we know in that sample. And then I actually believed in what they were doing, and then we agreed on going further on to do it as a research project. So what are they actually doing? Well, I don't know. They'll get some input from us, meaning the voice logs. They have a black box, as we call it, and then we get a result, cardiac arrest or no cardiac arrest. That's the easy version. We have a lot of people coming visiting our dispatch center for various reasons, and they're also interested in the AI, and they want to see the AI, and they get disappointed because it's just a black box attached to the CAT system. So the Corti people who are very inventive said, we have to make some Danish design. So they made it as a Danish design. So this is what it looks like now. There's a light there, and if the AI identifies cardiac arrest, it starts flashing. So the dispatcher will know. It also appears at the screen, actually. We published the results for 1 year of calls that we have already analyzed, listened to all the calls, tagged them, and were sure that these were cardiac arrest and what we missed and what we didn't miss. And as you can see, we took out some of them, those obvious deaths, and also those where we didn't have the voice log for some reasons at that time, and also the ambulance witness cardiac arrest we excluded. And they got about, for 100,000 calls they got 918 cardiac arrest in that sample. And these are the results, but let me make it short then and say, for these 108,000 calls we have, it's about 1% cardiac arrest in that sample when we exclude the EMS witness and the obvious death. And then we looked at human versus machine. Sensitivity for humans, 72.5, which was the PhD we have been doing. And the sensitivity for the machine learning was 84%. So it was less than the 19 initially, but it was still 10% higher than actually the humans. Specificity was about the same, and what is important, the positive predictive value was higher for the humans and lower for the AI, but still it's 1 in 5 that they identify that is cardiac arrest. And we know that the humans are always have a number of false positive in that case. So in numbers, it means that for these 918 calls, the medical dispatcher missed 253, and the AI missed 146. But it wasn't the same cases. So when you looked at it and combined it, I'll come back to that, then by adding AI, you get more identifying. The AI was also faster in identifying cardiac arrest, machine learning 48 seconds. Then you got a go for cardiac arrest or no go. And the dispatch, it took 79 seconds in average. So it's not only about these seconds, but it's also about the proportions being recognized by AI. And as I said, when you combine these things, you get a better prediction and an earlier prediction combining humans and AI. We also have an ongoing study now comparing with data from Seattle. Seattle have the no-go approach, meaning no breathing, no consciousness, go, consider this cardiac arrest, and start doing telephone CPR. And I thought that might be difficult to beat that early approach to that, but the preliminary data we have, which is going to be published, it is actually in review, shows that it's the same results they get out of an English population in Seattle. We have medical personnel in our dispatch center. They have non-medical personnel in the dispatch center, but have a very rapid response to acting as if this was cardiac arrest. But we get nearly the same results. And also it showed us that when we combined the Seattle data with the Copenhagen data, the model got even better. So AI is better in recognition of cardiac arrest by just listening to the call. So this was not about getting the medication, getting previous calls, getting data from the hospitals, getting demographics or risk assessment in any other way. It was just by listening to the calls. And I mean, the calls is usually 3 or 4 minutes or 2 minutes before it's identified. And of course, it continues to go on when you start CPR, telephone-assisted CPR. But if you don't realize that this is cardiac arrest, you send an ambulance, and then you usually end the calls. And then you might say, why? We got this part of the solution this morning because years of experience put into one model, the AI or machine learning will remember every call and use the pattern recognition, and there will be no human bias in what is said initially and where do we go and what do we think, what do we feel. So this is actually a continuous learning model they have there. Our dispatchers will get feedback on their calls, but they don't get feedback on every calls. And the feedback would take a long time to listen to the calls together with the call taker and give feedback on could you have done this differently and would it be possible to identify the cardiac arrest earlier or at all identified. And that kind of conversation takes a long time, and maybe you don't learn from that even though you hear it, but the AI doesn't care, it just learned and continue where it left. So that is it. Actually, we had some calls that the AI turned up saying, or the quality people went and we said, well, what are they identifying? And they could give some answers. They say, it seems that there will be something here that is not part of it, but high-risk patients. And when we look closer into that, it turns out that this was agonal breathing going on. The AI considered this as sounds, not words, not humans talking, not interviews, but just the sound which actually affected the outcome, and that was agonal breathing. The dispatcher would hear that as well, but don't recognize that this is actually agonal breathing, and we realized that afterwards. So the model could be even better than just the words and interview being done there. So what's the future in here? Well, we heard this morning, and I don't think that the future is in 5 or 10 or 20 years. I think it's right here. And it depends on how we in EMS want to take this on board. We can do that tomorrow. We need some documentation, but we could do that. And how far do we want to expand it? We went from gut feelings, which is accepted based on experience. I had a feeling that this was right or this was wrong, but I cannot explain it. It's just my feelings based on experience, or my artificial intelligence that is not conscious to me. And then to algorithms. But algorithms, we have a lot of algorithms in the dispatch centers, and it's so complicated. And you might have a right algorithm, but if you choose the wrong one and go down the line, you'll spend time and end up with a result which is not right for this patient. But integrating it can be done by using machine learning and AI in combination. So this is what I think is going to be the future of dispatch, what we're going to do. We need some more documentation, and we can also, I just wonder, how much data do we have on the monitors in the ambulance services? And what do we do with it? Maybe we print it out, maybe we send it somewhere, they look at the specific case, and then it's all forgotten because we don't go back and see the pattern in that. Maybe we could just send it to the sky, could be analyzed by AI, and next time somebody else is out seeing the same pattern on the screen, the same pattern on vital signs, in ECG, in vital signs in general, report back, AI could then report back saying, you should consider this, or this is the usual treatment, or this might be, or there's a high risk of. So you could get that kind of feedback immediately. I know the infrastructure is not there yet for sending things to the sky and getting them back immediately, but it will be there very soon. 5G is going to change what we're doing and what we can do, actually. And 5G, as we saw, is going to be introduced in Singapore very soon, so they will probably be leading in that field. I'll just give a short example here of how it could be in the future. This is made by Coty, so it's just to illustrate a call taking. What you see at the bottom, this is the Coty AI, and what you will see in the bottom will be the words being picked up and translated. It will not be visible for the dispatcher, but it's just to illustrate that this is the combination of word that will end up with an advice on how to go on. We need some...
911,
yeah,
what
thanks.
is your emergency?
I need help. I need an ambulance. Hey, Dad, what happened? Dad?
Can you please verify your name and address and tell me what happened?
Yes, I'm Annie Robinson. We're at 1450 Bay Street, San Francisco. My dad was installing kitchen cabinets, and I think he knocked his head or something. I just heard a bump, and then he fell. I can't get him up, and he's not being responsive. Dad, are you okay? Oh, my God, I think his head is bleeding. Oh, my God.
All right, give me one moment. Okay, an ambulance has just been dispatched, and it's on its way to you right now. Okay. They'll arrive in 4 minutes.
Okay. Okay.
And while we wait, can you tell me if your dad is conscious?
Yes, I think so. Actually, no, I'm not sure. I can't tell. His eyes are open, but his face looks all weird. I guess he's conscious. I don't know.
Okay, hold on. All right, we need to make sure that aside from hitting his head, there's nothing else wrong with your dad. Does he seem to be breathing properly?
No, actually, I don't think he's breathing right, but maybe he's just disoriented. I don't know.
Okay, Annie, this is important. He may be suffering a cardiac arrest, so if you're not sure, I'm going to walk you through how to check his breathing.
Oh my God, I thought he just fell and hit his head. Is he having a heart attack?
And so it continues with giving advice to the call taker based on what is said in the interview and based on the pattern that has been seen there. So finally, perspectives for emergency patient care. I think supporting decision-making in emergency calls and non-emergency calls is going to come. It's not going to be based on algorithms. It's not only relevant to emergency calls, it's also relevant to all the calls that we get from out-of-office services, helpline, medical helplines, GPs, and anywhere else that you get patients calls that could assist that. But we need data before that, old data, to actually learn the AI to work with that. It could also work in dispatch with other emergencies, strokes, sepsis, and trauma. We're going to start a stroke study. We have the data already. We have the results already. So it's just about learning the AI to identify the pattern of stroke, and that can be done within just 1 week or 2 weeks when they get the calls. The difficult part is to get the calls out of the system and then just run it through the AI. In my opinion, the triage tool, creating a triage tool that is making risk assessment is the future, so that we don't need a specific diagnosis. We need that if we're going to give advice on handling. AI can also support that, but just in risk assessment, if this is going to end up with an ambulance, if this is going to end up if the patient's going to end up in emergency department, or being hospitalized, or even in the intensive care unit, or if the patient is going to be dead within 48 hours or 1 week, if the AI is capable of predicting that, that would be very interesting. Not only based maybe on the call to the call center, but also based on combining data that we already have in the system about that patient and other patients. And we can do that in Denmark because we have a social security number like in Singapore, and we have access to that data, but the call takers will use that when they find it relevant. It takes time, it might be difficult, it might confuse them. AI would be able to assess that data very quickly and come up with a better solution. I hope so. So adding other healthcare data into the model would definitely improve them. And it would give guidance to dispatchers doing call taking. So we might see quite a different call taking system in the future, not based on algorithm. Coty says, when they are asked, they say, well, it's not going to displace the humans. It'll always be humans taking the final decision. I'm not sure anymore. I'm not sure. Maybe the AI could take the call initially and triage it, and then you could involve the human if it's get more difficult, or if it's special cases, or just confirming what's going on in the end. Just like we do with dispatch today, the logistics about the vehicles. It's done already, making this car going there, and then just confirm it. So we don't know what the future will bring. I'm quite sure we will benefit from AI in emergency medical services, and we need that kind of support to make better decisions than we are already doing. And most of us are not measuring what we're doing, so we don't know how badly we're doing and how much we actually could improve if we wanted to. So in summary, identifying cardiac arrest is essential. We have had the first medical publication of using AI or machine learning in identifying cardiac arrest, and it turns out that artificial intelligence seems to be better than humans. We're doing a randomized controlled trial now in Copenhagen. It will end in 3 months, and then we have the results there. We are looking for partners to further explore AI in call centers, dispatch centers, and also looking for partners here in Australia. And I've already got some who's interested, and which is very good. Thank you very much.